This discussion is going to center around the different types of medications used in managing diabetes. So particularly for the active population, obviously people can still be very active with diabetes. It's very important to make sure that diabetes is controlled to make it that there's not going to be any type of associated issues with the diabetes that come about. So we're going to talk about everything from kind of how we control blood glucose to what happens in the two different types of diabetes, and then some of the common medications used to manage diabetes. So looking at the physiology as to how the body controls blood glucose, there's a little picture here on the slide kind of going through the process for how the body kind of responds to both low blood glucose levels and high blood glucose levels. So I'm not going to go through and explain this. This should actually be something that you've gone through in the past, and even if you have not or you've forgotten, this kind of takes you through the process. So I want, as a part of the discussion board for this topic, okay, there's two questions posed on here. How does glucose metabolism slightly differ with the specific organs? So looking at low and high blood glucose, what do the organs involved do? And it's pretty much spelled out for you on here anyway. And then look at how does exercise affect this process? So in other words, how does exercise affect the control of blood glucose? And for that, again, you can utilize your textbook as well in your response. So in looking at what diabetes is, so diabetes is a condition where the body can't regulate blood sugar. Now there's two different types of diabetes that we're going to talk about here. They're not the only two types, but these are the two primary types you typically consider. So type 1 is your insulin dependent diabetes mellitus, or what's sometimes referred to as juvenile diabetes. So this is a condition where the body does not produce insulin, okay, or starts to not produce insulin. So they believe it's due to autoimmune destructions of the beta cells in the pancreas. Typically what you'll see are individuals who have very high fasting blood glucose levels. So type 1 involves the non-production of insulin, whereas type 2, what we call non-insulin dependent diabetes mellitus, or what typically referred to as adult onset diabetes, albeit there are more younger individuals developing this, where you have increased cell resistance or decreased insulin production. So what you essentially have with this a lot of times is not so much that you typically have a huge decrease in insulin production, but what happens, sometimes the body can actually produce more insulin. It's a situation where the body doesn't know how to use it. So the body will produce insulin, but the body doesn't use the insulin as effectively, and it causes a rise in blood glucose. And typically what you see with this is a high correlation with obesity. So older adults who are overweight will have a greater tendency to put themselves at risk for the adult version. As I said, some younger individuals are developing this. There's been a slight rise in that, so that's something to be aware of as well. So these pictures just kind of illustrate what is going on with type 2 diabetes. Again, type 2 diabetes is insulin resistance, so your body's producing it, but you're just not as sensitive to the insulin. So again, it's kind of a situation where the body kind of forgets how to utilize insulin. So you see on the picture there, the insulin receptors don't cause what are known as the GLUT4 receptors to bring the glucose into the cells, which is going to cause a sharp rise in blood glucose. One way to limit your chance of developing insulin resistance is actually exercise causes your body to use less insulin than needed to bring glucose into the cells. So the GLUT4 receptors, through exercise and activity, actually become more sensitive and are able to take up glucose without using a lot of insulin. So that's one of the benefits of just being an active individual. And again, inactivity and being overweight will cause someone to, again, their bodies not to be able to utilize the insulin as well. And the other picture is just basically showing what's going to happen. Because of the insulin resistance, the blood glucose is just going to continue to rise. So typical characteristics of type 1, the onset is going to typically be in adolescence. The family history is typically negative. And again, it's primarily believed to be caused by an autoimmune condition. So if you remember, an autoimmune disease is where the immune system attacks the body's own cells. So, and it's believed here that causes a breakdown in the beta cells in the pancreas. Your symptoms are listed on here. Usually the person body weight wise will have a normal body weight, or sometimes they'll be slightly underweight. Again, no insulin will be produced, and the primary management for this is usually going to require some type of supplemental insulin, and the regimen will kind of be determined based upon how the person is able to manage their blood glucose. Typical characteristics of type 2, what you usually see with this are, again, older individuals that are usually a gradual onset. As far as the etiology, they're not quite sure. Again, we assume that being overweight and being sedentary has something to do with that. You could refer to page 66 in your textbook just to kind of look up some of the things associated with type 2 diabetes in regards to the etiology. It can be asymptomatic for years. When they do start to have symptoms, they can be similar to type 1. Again, usually what you experience with this is with overweight individuals who tend to be very sedentary. A lot of times, as I stated previously, sometimes insulin levels can be down a little bit, but it's not uncommon for the insulin levels to be normal or even high for that matter, because their body's going to start to produce more insulin because the insulin doesn't work as well. So that's kind of one of the defining characteristics of type 2. As far as the management for it, we'll talk about some of the different medications that get utilized for this. It obviously doesn't always require supplemental insulin. There's some other things that can be utilized. Some people control this heavily with diet and exercise, but we'll talk about some of the other medications that are commonly used to treat this. Again, a big part of the reason why it's so important that diabetes gets managed appropriately, and again, individuals' management is going to, again, be individualized based upon, how often they have issues associated with the diabetes, how well they control their diet. So here's a list of some of the possible issues that can occur. A lot of the reason why these individual issues occur typically is due to circulatory problems caused by the diabetes. So the rise in the blood glucose will kind of predispose the person to develop fatty deposits within their blood vessels, producing circulatory issues. So many of these things associated with complications to diabetes are associated with circulation. So I'm not going to go through each one of them individually. They're listed up here. I'll leave the slide up for a little bit so you can kind of see, but I also have these in the notes, so just be aware of these as your complications. And this is just a picture kind of reinforcing what I was discussing previously. So you see it's not uncommon, particularly in the feet, to develop the diabetic ulcers, again due to circulatory issues, and here kind of showing the plaque forming in the artery walls of the heart. So various types of complications, again usually associated with the circulatory system and the nervous system playing a pretty significant role. So this is your diagnostic criteria when you're looking at getting diagnosed with diabetes. So again, signs and symptoms obviously being an important part of that. So signs and symptoms plus blood glucose greater than or equal to 200 milligrams per deciliter, and or a fasting blood glucose greater than 125. Obviously, if you're fasting for 8 hours, your blood sugar should be low normal for this. So if it's greater than or equal to 125 for a fasting blood glucose, that would be diagnostic criteria as well. So looking at management of diabetes, the most common management thing is monitoring blood glucose is going to be one of the most important things, obviously, with this. You will see many individuals with diabetes using the small blood testing kits as shown in the picture. That's going to be used for daily and immediate blood glucose monitoring. So it'll tell them at any point in time what their actual blood glucose is, and then obviously they will manage their medications based upon how that's being controlled. If you're looking at fasting and 2 hours post-meal, you should typically be looking at having a blood glucose less than 100 milligrams per deciliter. The hemoglobin A1C, or what's known as the HbA1c, is the glycosylated hemoglobin levels. What this does, this is something that gives you more of kind of an overall control of blood glucose. So it should be less than 6%. And what it is you typically will do this about every 3 months. Why this gets utilized is because it kind of gives a better overall picture of the person's blood glucose, and it's not as affected by daily fluctuations in blood glucose. So day to day, it's not uncommon. I mean, you don't want big fluctuations to have that happen, but the HbA1c will give a physician kind of a better idea as to how the person is doing overall in controlling their blood glucose levels. Now, some general management guidelines. In looking at exercise is a very important aspect for management of both type 1 and type 2. And we're going to talk about the different reasons why. First of all, a discussion board question which will be posted. How should people who exercise manage their activity based on whether their blood sugar levels are low, normal, or high? So whether they have, even if it's a normal blood sugar when they take it right before exercise, if it's on the low end, what should somebody do? There are things that people should do in managing their blood sugar with exercise. So I want you to look that up and post in the discussion board what that would be. Exercise does facilitate glucose uptake. I talked about this earlier. When a person is very active, so let's even take it beyond just looking at people with diabetes. Let's take a look at someone without diabetes. Someone without diabetes exercises, particularly strength training. If someone strength trains, their body is much more efficient with utilizing insulin. In other words, they don't need as much insulin as somebody who is very sedentary. So if you strength train, your body will take up your blood glucose much more efficiently than it would if you didn't. So this is actually the primary therapy for type 2. They try to treat type 2 diabetes without drugs. They try to do it with exercise and diet first, if that's possible. Now, it's only supplemental therapy for type 1 because obviously if you have type 1, your body is really not producing insulin. So you still need the insulin to do that. So there's always a balance between food and insulin for type 1, and again, that's why I want you to look up the answer to that question. So you have to be aware of what your blood glucose is and what your insulin levels are before exercise. And I just have a question down here. It's not an assignment or a discussion board question, but it's something I want you to kind of look up and just jot a couple notes down to yourself. What are some other ways athletes can manage type 1 diabetes? So I just want you to take a look at that again. The discussion board question up top, this one is just more or less just a thought question for you in general. So your drug management for type 1, again, it's going to be insulin because they're the insulin-dependent type. With type 2, ideally, if it can be managed with diet, weight loss, and exercise, that's what is at least the initial, as long as the person isn't that poorly controlled. They also will take oral hypoglycemic meds and sometimes insulin. But again, remember, with type 2 diabetes, usually it's an issue of, Not so much that they don't produce insulin, but they produce, and in some instances they actually produce a lot of insulin. Their body just doesn't know how to utilize it. Now, in looking at the areas of insulin injection, so the absorption rate varies depending on where you inject it at. There's various areas, and you can see on the slide on here, and it might be a little hard to read. It shows the absorption rates. So this is also a picture that's in your text, so you could also refer to that. One of the faster areas of absorption is the insulin, or as the abdomen rather. A lot of people who exercise should avoid the thighs, only just to avoid increased absorption into the thigh, because obviously when you start to exercise, even though it shows that it's a slower speed area, when you start to exercise there's increased blood flow to the area, so you'll get an increased absorption into the muscle if you have a tendency to inject into that area. So most people who are very active should likely utilize the abdomen as their primary injection site. Some other management issues, particularly with insulin, you want to make sure that for long-term storage that you're cooling it, so it needs to be refrigerated. You want to make sure that you're kind of checking the quality of it, so any clumps or frost or anything like that, it'll probably have to be replaced, but it should be refrigerated for long-term storage. Some of your different needles, and there's some other injection devices that we're going to be going over. Typically a small gauge needle is a pretty common thing. It's a subcutaneous injection into the individual. I have another discussion question that I want answered in the discussion board. So what are some points an athletic trainer needs to consider if he or she needs to inject an individual with insulin? So if you're the athletic trainer, what do you need to consider if by chance you would ever have to inject them with insulin? Some other types of devices used for injecting insulin, there's probably even others beyond this since this was put together, but there's different types of pre-filled devices as well. There's pre-filled pens with set amounts of insulin available to them, so patients don't have to worry about the filling up the actual syringe. So just an overall review of looking at the different aspects of insulin injection. You have to be aware of the different absorption rates of the different sites. Again, it is recommended that individuals who are active and exercise to utilize the abdomen as their primary source of injection site. You want to make sure that insulin is stored appropriately, and again, just as far as use, the different types of needles and injection devices of the various types of means of injecting that we talked about. So now we're going to look at the various types of insulin that we have. So, and I want you to be able to, I'm going to expect you to be able to recognize the different types of insulin, the names, whether they're rapid acting, short acting. So, make sure you're making note of all this. I'm certainly not really going to look for you to be able to quote unquote prescribe, because you're not going to be doing that or be able to answer how it should be put together, but you should be able to recognize the different types. So you have your rapid acting, which is a 15-minute, basically goes into action about 15 minutes. The duration it lasts for is about 2 to 4 hours, and you have the different types listed there. You have your short acting, which begins working in about a half an hour to an hour and lasts for about 5 to 10 hours. Then you have your intermediate acting. So you see the onset of action begins to happen later and later, and the duration goes longer depending upon the type that you're looking at. Again, take a look at the names on here. Your textbook also, lists the names, so just be able to recognize those different types. Then you also have your long acting. Again, you see the onset of action and the duration, again, extending a little bit further. You also have combination types, where you have a combination of a short and long. Again, all of these different types really is going to be at the discretion of the physician based upon how the person controls their blood sugar levels, how active they are. All of those different things are going to kind of play a role. So I'm not posting this on the discussion per se for you to answer, but it's something I want you to kind of think about, and you can look at this in your text. How does the type of insulin and timing of administration coincide with meal timing? So it's just a thought question. You can jot it in your notes. I'm not gonna have an actual hand-in assignment online for that question, but kind of take a look at that and understand. And by all means, if you have questions about that, let me know. So just some basics on insulin regimens. So, a lot of times people will use if they use a combination product, they'll use it 2 times a day, and that'll usually be before breakfast and before dinner. Depending upon monitoring, they may throw in additional doses. Again, a lot of what insulin doses get adjusted for are the individual's activity level and what type of food they're eating. Again, it's still really important, even though the individual has the option to utilize insulin, that they eat a good diet for a diabetic. Sometimes, just like anyone else, it could be all right to stray from that and just adjust their insulin, but ideally they're not having huge swings with that very often. So it's very important that they're eating appropriately as well. Figure 5.8 in your book can also show you some different examples of combo therapy. So kind of just take a look at that so you can see how a lot of that is set up. So your adverse effects. So hypoglycemia or insulin shock. So that's when the blood sugar drops. So if an insulin-dependent diabetic does inject insulin and maybe they don't eat, or their blood sugar is kind of, again, that low normal, and they don't have anything to eat and their blood sugar drops, they will go into insulin shock. This usually is a pretty rapid onset, and what it requires, it's pretty easy to treat. 15 to 20 grams of a fast-acting carb will help treat it, and we've probably all seen, or you've probably seen at your clinical sites, that a lot of ATCs carry glucose gel or those glucose tablets that basically represent that 15 to 20 grams of fast-acting carbs. If by chance the glucose levels get really low, a lot of diabetics will also have what's called a glucagon kit. If you remember, glucagon is the hormone in the pancreas that helps to release stored glucose. So if the blood sugar levels get extremely low and they need a glucagon injection, they will have that available as well. Now, diabetic ketoacidosis involves the increase in blood sugar. So you'll see this a lot of times in individuals whose blood sugars rise as a result of a decrease in the glucose uptake by the cells. So this will be caused by increased blood sugar levels. So insulin shock is low blood sugar, diabetic ketoacidosis is high blood sugar. What's going to happen is the fatty acid metabolism is going to increase because the body's not going to be able to utilize glucose for energy, so you'll get the development of those ketone bodies, which causes one of the, I guess you'd call it one of the hallmark signs and symptoms of this. The signs and symptoms, it's a slow onset. So this is, when you look at differences between diabetic ketoacidosis and insulin shock, there are some things that kind of set it apart. There are sometimes, though, it does get a little tricky clinically because they can show some similarities. But these are typically what you'll see with the diabetic ketoacidosis: thirst, excessive urination, fatigue, blurred vision. Fruity breath is going to be caused by the increase in ketones. The breathing difficulties, the nausea. The nausea could sometimes also happen with the low blood sugar, so again, you got to be wary of that. Rapid, weak pulse, low blood pressure. Now, as far as the treatment for this, the individual will, this will require somebody to be directed towards a hospital immediately because of the fact that this can lead to coma and potentially death. So that's going to be important for that, and it's going to be important that they get insulin in this instance. If you're unsure of whether somebody has insulin shock or ketoacidosis, so say you're kind of in between and you're not sure, you could give them 15 to 20 grams of a fast-acting carb. If they get better fast, then they have insulin shock, low blood sugar. If they don't, then that they have diabetic ketoacidosis. So, and you don't have to worry that the 15 grams of carbs isn't going to, throw them over the edge. So that's important to know. So they have to be given IV. If they have diabetic ketoacidosis, they have to get IV fluids, and they have to get insulin. They have to get treated for that. So it would be important that treatment commence very quickly. So some other adverse effects, and a lot of this just comes from the injection site. You could have lipohypertrophy. Sometimes the area around the injection might get a little bumpy from the little fat cells in the region kind of hypertrophying a little bit. Or you could have just the opposite. You could have lipoatrophy, and what will happen is the adipose tissue will get broken down. There may be like a little indentation in the area, so just some minor skin imperfections that could occur, and then any type of just general local skin reaction, pain, swelling, redness, itching can also occur as well. Now, for the oral anti-diabetic agents, these are essentially used for individuals with the type 2 diabetes. So again, the individual who's producing insulin, or in some instances producing a lot of insulin, and their body just doesn't know how to use it. So a lot of these different anti-diabetic agents just in various ways help with the breakdown and usage of the glucose inside the body. So basically, if diet and exercise fail for type 2, they get prescribed medication if they're having trouble with this. So I have a little note up here. Look at figure 5.9 so you could see, one of the things I want you to be aware of is where some of these different anti-diabetic agents kind of work at. As you see going through them, they all basically do the same thing, they just do it in different ways. So your alpha glucosidase inhibitors, they basically inhibit the breakdown of poly to monosaccharides. So it kind of decreases, again, some of that buildup of the glucose in the body, whereas something like metformin is going to decrease liver glucose, decrease intestinal absorption, and increase peripheral uptake. So kind of make note of those mechanisms of actions in some of the different types. Again, here are some more oral anti-diabetic agents. Again, as I had said on the previous slide, we have a couple more coming up. Again, be aware of where their action takes place, what they do, and be able to recognize the names. And again, some other oral anti-diabetic agents. Again, you see here with this one, it increases insulin release from the pancreas and decreases insulin resistance in the liver. So again, important to note mechanism of action when you're examining these. And just like with insulin, you have combination drugs. So again, there's a lot of different drugs. It's not going to be obviously under your responsibility to figure out what they should take, and I'm not going to ask that type of question on an exam, but I do want you to know how they work and be able to recognize the different types. Again, this will be a decision made by the physician that the individual's working with, and in kind of what suits them the best, as far as lifestyle, as far as how they're able to eat. Again, ideally, for a type 2 diabetic, if you could control it with just diet and exercise, that's really the way to go. and that you'll have the most benefits that way and not have to take a medication. So the role of the ATC, because this is going to be what's really relevant to us. Obviously, helping with the detection of issues, again, noting signs and symptoms if they do come up. Just being aware of who has diabetes. Obviously, if you're working in a classical sports setting with a team, this is where health histories are important. If you have a diabetic, it's probably a good idea to meet with them. Talk about what they do, find out how well controlled they are. I have been fortunate in my experience. All the diabetics I've had have been pretty well controlled. I've never really had a diabetic athlete that I've ever worked with that's ever really had a whole lot of issues. Asthma, on the other hand, that's a different story. But definitely I've been fortunate enough to work with a lot of athletes who were diabetic, but were able to control themselves, and they were also able to detect things very quickly within themselves to where I never even had to help them. They might come to me and say after a practice or after a game, I was starting to feel this way, but I did this, and that's how I took care of it. So have your emergency procedures in place. It's a good idea to have some type of fast-acting carbohydrate if you do have an athlete that has that. Some athletes may even have an insulin pump. That may be how they control their insulin. I didn't really talk about those at all, but an insulin pump is basically an insulin device attached to the individual, and they just kind of turn up and turn down their insulin as they need to. Some athletes may have those, and it's going to be important for you to figure out how they get utilized with the athlete, so be able to be aware of that. And it's good just, again, to know, just as it would be with any health condition that an individual would have, be able to kind of monitor them while they're out there, so that can certainly assist in making a lot of, preventing or recognizing a lot of early signs of different situations. And again, as always, just a summary of your learning outcomes. So again, address those different discussion board questions that are posted on Blackboard, and also be able to look at those other questions. Again, every question I ask isn't going to be a discussion board question, but again, like I've done in the past, keep people active, make sure you're looking at your book. I'll ask some of those other questions that if you print out the note sheets that I give you, you can just jot down some notes. Just something to make yourself aware of in case I were ever to ask like a test question or something like that on one of those topics.